Dr. Jayashree Petkar and Dr. Archana Chaure to be on the dais. I welcome you both. It gives me great pleasure to introduce our judges for today. Dr. Jayashree Petkar is Professor and Head of Department at PCMC's Postgraduate Institute and YCM Hospital, Pune. And our second judge, Dr. Archana Chaure, is Associate Professor from Srimati Kashibai Navle Medical College, Pune. Okay, so we will be starting our presentations. Before starting the presentations, I'll brief the rules. Every presenter will be given total 9 minutes, of which 7 minutes are for presentation and 2 minutes are for question-answer round. First bell rings after 5 minutes and second bell will ring at the end of 7 minutes. In case presentation exceeds 7 minutes, then there will be no question-answer round. So let's start today's oral paper presentation. I request our first presenter, Dr. Sonakshi from GMC Nagpur. Her topic for presentation is bacteriological profile and antimicrobial resistance pattern of pathogens isolated from tracheal secretions at tertiary care hospital with special reference to VAP.
Friends, this is my topic for today, bacteriological profile and antibiotic resistance pattern of pathogens isolated from tracheal secretions at tertiary care hospital with special reference to ventilator associated pneumonia, that is VAP. So introduction, as we are already aware of the fact that mechanical ventilation is a life-saving procedure, but it is associated with a high risk of respiratory infections along with high morbidity and mortality in critically ill patients. VAP is the second most common nosocomial infection, accounting for 15% of hospital-acquired infection. Incidence varies between 5% to 40%, and so depending upon the setting and diagnostic criteria. Mortality ranges from 24% in 15 to 19 years and 60% for patients above 85 years. Antimicrobial resistance and inappropriate empirical antimicrobial therapy is adversely affecting outcomes in VAP. So despite advances in patient care, their changing floras are complicating their therapy. So my aims and objectives are to study the spectrum of aerobic bacteria isolated from tracheal aspirates of patients on mechanical ventilation, to determine the antibiotic resistance pattern of these isolates, to correlate the organisms isolated from tracheal secretions and organisms that are causing VAP. Material method, this is a cross-sectional study conducted between June 2021 to June 2022, and the tracheal secretions of patients on mechanical ventilation for medicine intensive care unit were taken, and the drugs were used according to CLSI guidelines 2022. Methodology, these cases on mechanical ventilation were further followed for development of symptoms of VAP. A patient was said to be suffering from VAP if he or she is on mechanical ventilation and developed fever and cough with purulent sputum in combination with radiological evidence of new or progressive pulmonary infiltrate and a suggestive gram stain and growth in cultures after 48 hours of hospitalization. So these are the results. Out of the 73% of significant growth, we got 80% of monomicrobial and 19% of polymicrobial growth. Out of different organisms which were isolated from cultures of tracheal secretions, Acinetobacter baumannii was in majority, followed by Klebsiella pneumoniae. So this is the resistance pattern of enterobacterials, and in this we can see gentamicin is the least resistant, followed by ampicillin is the most resistant. Among non-fermenters, meropenem accounts for majority of the resistance, and ampicillin is the most resistant, meropenem is the least resistance. So we saw that 80% of gram-negative bacilli were multi-drug resistant. 3 strains of Staphylococcus aureus were isolated, out of which 1.46% were MRSA, and they were sensitive to gentamicin, doxycycline, and linezolid. Out of 205 clinically suspected cases, 40 were confirmed as VAP, and the VAP rate was 10.7 per 1,000 ventilator days, and the organisms which were causing VAP were most commonly Acinetobacter baumannii, followed by Klebsiella pneumoniae and Pseudomonas aeruginosa. So discussion, in our study, the most common isolate was Acinetobacter baumannii, and that correlated with Garg et al., Gowda et al., and Swati et al., and that may be due to the dramatic increase of Acinetobacter baumannii to the limited virulence, their extraordinary ability to develop resistance, and they are spread by aerosols. And the airway intubation is associated with increased frequency of gram-negative bacterial colonization or upper and lower respiratory tract infections. So our resistance pattern of gram-negative bacilli correlates with these following authors. 80% of MDR were correlated with Joseph et al. And Gupta et al. And that may be due to new mutations, selection of resistant strains, and suboptimal infection control, and also may be due to the longer periods of mechanical ventilation and hospital stay. And our VAP rate correlated with Ali et al., Asir et al., and Rao et al., and that may be due to the strict vigilance on infection control practices and VAP prevention care bundles. And our organisms causing VAP correlated with Garg et al. And Swati et al. So to conclude with, the present study deals with two microbiological complications. First is high growth rate. Hence the isolation, identification, and antibiotic susceptibility testing of bacterium isolated from tracheal secretions, they help in prompt confirmation of etiological agent, and ultimately they will enhance the treatment guidelines. Secondly, there is a presence of high number of MDRs. So once the MDR is established in the hospital, it will persist and it will act as a source of nosocomial infection, and the resistant bacteria that will survive the effect of the antibiotics, they will spread to the others as well as to the families, community or healthcare settings. Lastly, so therefore in vitro testing of antibiotics and careful microbial surveillance that will bolster the prevention and treatment of VAP. So these are my references. Thank you.
Any questions?
Okay, nice presentation. In your discussion and results, you said there is significant growth of some organism. So can you describe what is meaning of significant growth in your case?
Ma'am, out of the tracheal samples we collected, the organisms which were causing VAP, there were many samples of tracheal aspirates, but which were showing the organisms, the growth of organisms, they were significant, and out of which were causing VAP, which were clinically suspected, and we labeled it as VAP. So the clinically suspected cases were the organisms which were taken out from the tracheal aspirates.
Nice presentation. I want to ask one question. How you have calculated the VAP rate?
VAP rate is the number of patients on mechanical ventilation upon the number of ventilator days into 1,000.
Any question from audience? Any question from audience? Thank you. Thank you, Dr. Sonakshi. Now I request Dr. Petkar to award her the participation certificate.
In the pathogens isolated. This is a retrospective cross-sectional study undertaken from January 2017 to December 2021 for a duration of 5 years in the Department of Microbiology of Grand Government Medical College and Sir J.J. Hospital, Mumbai, undertaking a sample size of 792 cerebrospinal fluid samples from clinically suspected cases of post-operative neurosurgical infections. 792 cerebrospinal fluid samples from clinically suspected cases of post-operative neurosurgical infections were received for culture and sensitivity. Gram stain and wet mount were performed on them. They were further inoculated onto sheep's blood agar, McConkey's agar, chocolate agar, and Sabiro's dextrose agar and incubated at 37 degrees Celsius. A duplicate of Sabiro's dextrose agar was also incubated at 30 degrees Celsius. For those that were culture positive for bacteria, they were further identified based either on standard biochemical reactions or Vitek to automated systems depending on the availability of ID and AST cards. Further, antibiotic susceptibility using Kirby-Boyer diffusion method was performed on them, and they were further interpreted based on CLSI 2017 to 2021 recommendations. For fungi, the Sabiro's dextrose agar were constantly monitored for growth. For those that were culture positive on Sabiro's dextrose agar, Lactophenol cotton blue mount was performed on them to identify the fungus based on microscopy. Coming to the results, a total of 792 cerebrospinal fluid samples from clinically suspected cases of postoperative central nervous system infection were analyzed. Culture was positive for 152 specimens, that amounted to 19% of the samples. Out of the culture positive, 28.8% showed infectious complications and 73.3% showed no such complications. Among the infectious complications, those that had external ventricular drain inserted amounted to the most, that is about 38.4%, followed by those with medium pressure ventricular peritoneal shunt, that amounted to 30.7%, followed by those that had subgaleal hematoma, that amounted to a percentage of 15.38%. Lastly, those with hydrocephalus without shunt and those with wound site infection amounted to 7.69%. Culture positives, among the culture positives, 46 were female and 105 were male. Gram-negative bacteria were isolated from 129 samples, gram-positive bacteria from 22 samples, and Candida glabrata from 1. Among the gram-negative bacteria, Acinetobacter baumannii was the most commonly isolated, that is from 52 samples, followed by Klebsiella pneumoniae, isolated from 27 samples, followed by Pseudomonas aeruginosa, that was also isolated from 13 samples, followed by non-fermenting gram-negative rods that were isolated from 10 samples. Among the gram-positive bacteria, Enterococcus species was the most commonly isolated, that is from 9 samples, followed by methicillin-resistant coagulase-negative staphylococci and methicillin-resistant Staphylococcus aureus, both that were isolated from 5 samples each. Most of the gram-negative isolates were multi-drug resistant. They were most susceptible to carbapenems, that is meropenem and imipenem, followed by aminoglycosides like gentamicin and amikacin. Among the gram-positive bacteria, methicillin-resistant coagulase-negative staphylococci and methicillin-resistant Staphylococcus aureus showed 100% susceptibility to linezolid and vancomycin. Enterococcus species showed the most susceptibility to vancomycin, followed by gentamicin. In conclusion, multi-drug resistant gram-negative bacteria were the most prevalent cause of infection in postoperative central nervous system infection. Among the non-fermenters, including Acinetobacter baumannii, Pseudomonas aeruginosa, and other non-fermenting gram-negative rods, was the most prevalent cause of infection. In a study that was conducted in China, methicillin-resistant coagulase-negative staphylococci was the most predominant organism as compared to Acinetobacter baumannii in our study. In another study meanwhile, in another study performed in India, Acinetobacter baumannii was the most commonly isolated organism, which showed the same results as the present study. Early diagnosis is essential for management of post-surgical infectious complications effectively, and the timely use of antibiotics guided by the identification of the causative pathogens and their antibiotic sensitivities is essential for treatment, which can help clinicians choose the appropriate empirical antibiotic therapy. These are my references. Thank you.
In your findings, you have mentioned Acinetobacter baumannii was the commonest pathogen which was isolated. Why Acinetobacter baumannii is a common nosocomial pathogen?
Nice presentation. In your study, you have taken different neurosurgical procedures. So among that, VP shunt was there. So what was the most common organism isolated from VP shunt patients?
Acinetobacter baumannii.
Thank you. Please collect your participation certificate from Dr. Archana. Now I invite our third speaker, Dr. Swati from Sahyadri Specialty Labs, Pune. Her topic for presentation is study of ESBL producing and carbapenem resistant gram-negative bacteria from urine culture samples.
Good afternoon all. I am Dr. Swati Pathak. My topic is study of ESBL producing and carbapenem resistant strain of gram-negative bacteria from urine culture samples. So urinary tract infection are among the most frequent infectious disease affecting humans and represent an important public health problem with substantial economic burden. UTI are primarily caused by gram-negative bacilli, that is GNB, and in that, main pathogen responsible for uncomplicated cystitis and pyelonephritis is Escherichia coli, followed by other enterobacterial species like Klebsiella pneumoniae, Proteus, Morganella, Enterobacter, Citrobacter, followed by non-fermenter, that is in that most common was Pseudomonas. Then among gram-positive cocci, there are Enterococcus faecalis and Staphylococcus saprophyticus. So incidence of this ESBL producing and carbapenem resistant gram-negative bacteria among Enterobacteriaceae group are increasing and becoming the threat for effective treatment of UTI. Clinicians who treating these infections caused by drug-resistant pathogens have few effective antimicrobials to choose from, and many are associated with significant adverse effects. There are now multi and sometimes the pan-drug resistant organisms that could be encountered in clinical practice. Therefore, it is very crucial that the spread of this resistance to be accurately monitored and controlled. To evaluate such resistant pattern, we conducted this retrospective study from April 2017 to March 2022 of all urine samples received for culture in our laboratory. So, data considered for this study was spanned from April to March 2017-18, 18-19, 19-20, 20-21 and 2022. Urine sample from all tertiary care hospitals were received in our lab, and we cultured on clade agar media, that is cysteine lysine electrolyte deficient agar medium with semi-quantitative method, and growth was observed on next day. According to the growth, GNB or GPC, identification and sensitivity was performed on Vitek to compact system, and then interpretation was done according to CLSI guideline, and data was analyzed for ESBL producing strain, carbapenem resistant strain and colistin resistant strain. So here are the results. In this 5-year study plan, total number of urine culture sample were 4,963 in 2017-18, were increased up to 11,381 in 2021-22. And total percentage of growth remains 30 to 31%. If we see the organism-wise distribution, E. coli was the main culprit for these all urinary sample, followed by Klebsiella pneumoniae, then Enterococcus species, followed by non-fermenter that are Pseudomonas, and in others there are miscellaneous, that is Proteus, Morganella, Enterobacter and Citrobacter. So in our laboratory's data, the Enterobacteriaceae group is the predominant culprit. So if we see the in that there are carbapenem resistant strain was only 13.4% in 2017-18, were increased up to 21.97% in 21-22. And colistin resistance was observed only 0.6% in 17-18, were increased up to 1.4% in 21-22. And if we observe that E. coli was the most common organism among Enterobacteriaceae group, in that also carbapenem resistant strain were only 7.3% in 17-18, which were increased up to 16% in 21-22, and colistin resistance were almost negligible, that is 0% in 17-18, were up to 0.5% in 21-22. Followed by that, second most common culprit was Klebsiella, which was always known to be more carbapenem producing strain. So it is always higher carbapenem producing strain, which was 29.7% in 17-18, were increased up to 37.1% in 21-22. And colistin resistance also 2.4% were increased for 3.3%. Miscellaneous organism remains sensitive. There are no specific carbapenem strains observed in this study period. Followed by that non-fermenter Pseudomonas, which was also carbapenem resistant strain were 45.1%, were increased up to 55% in 2021. And in between also 63% was also observed. So this increasing trend of carbapenem and colistin resistance was observed constantly over this study period, which was alarming and limit the choice of antibiotic for treatment. In our study, E. coli continued to be the most frequent cause of UTI, followed by Klebsiella pneumoniae was the most common carbapenem producing a bacteria, and then E. coli and Pseudomonas. Colistin resistant strain are also higher in Klebsiella pneumoniae. One surprising feature is that Klebsiella pneumoniae's carbapenem producing rate is always higher, but percentage changes in carbapenem production is E. coli is higher than the Klebsiella pneumoniae in 5-year study period, which was also alarming. So what could be the probable causes? In this study period, there is an advent of COVID pandemic, which may increase the catheterization rate. There are secondary bacterial infection due to the decreased immunity status due to COVID. High dose of steroids and immunosuppressive therapy also further decreasing immunity, which allow infection from resistant strain. Overuse of antibiotic to prevent this secondary or infection leading to increase in resistance, and doubtful catheter care during COVID isolation. It could be the all reasons. So in short, conclusion is that high rate of multi-drug resistance were observed among the Enterobacteriaceae uropathogen, and we have to emphasize regular monitoring of these resistant strain with UTI. So judicious use of antibiotic must to control such resistance development. Thank you. These are my references. Okay, sorry.
What is the clinical significance of ESBL producers?
ESBL producers? Ma'am, in my study, what I observed, when carbapenem production is going higher side, ESBL production will be on lower side. So it is not that ESBL producing is going down, so a sensitive strain will increase. It will emphasize that ESBL producing strain going down, and simultaneously carbapenem resistant strain will increase.
From treatment point of view, would you like to give some suggestions to the clinician?
Yes, ma'am. If carbapenem resistant strain is more and more, then newer drugs like phosphomycin for urinary tract infection specifically. In Enterobacteriaceae group, mainly E. coli and Klebsiella are effective. And some aminoglycosides can be used if they are in a sensitivity pattern shows the sensitive.
Nice presentation.
Thank you, ma'am.
In your study, you got colistin resistance, right?
Yes, ma'am.
So by which method you have detected it?
Yes, ma'am. Pardon?
By which method you have detected it?
Ma'am, we are doing in only Vitek 2 machine.
Okay. Enumerate the other methods used for
Yeah,
colistin resistance, and which one is preferred method?
According to CLSI guideline, colistin microbroth is preferred method, and we have it, but we are not doing it in every colistin resistant strain. If we think that this patient is previously sensitive and now suddenly became resistant to all these things, then we consult with the consultant and then do this microbroth along with the Vitek and compare both the study. And in our knowledge, whenever we do these both things, most of the times results get same. In Vitek also colistin resistant, and in microbroth also colistin shows the resistance.
Any questions from audience? Thanks, Dr. Swati. Now I request Dr. Jayashree to award her the participation certificate. Dr. Neha to present her presentation. Her topic for study is Study of Bacteriological Profile of Post-Operative Wound Infections in Surgical Wards and the Antimicrobial Resistance Pattern in Tertiary Care Hospital. She is from GMC Nagpur.
Good afternoon, respected judges, seniors, and everyone present here. My topic for the presentation is Bacteriological Profile of Post-Operative Wound Infections and their Resistance Antimicrobial Pattern in a Tertiary Care Hospital. As we all know that surgical site infections are the most commonly reported nosocomial infections, and its incidence varies from 2 to 20% in developed countries as high as 40% in the developing world. Despite improvement in prevention, it still remains a significant problem. Therefore, it is essential to know the pathogen causing the infection and its resistance pattern. The aim of the study is to study the prevalence of bacteriological pathogen causing SSI, and objective is to isolate and identify the bacterial associated with SSI cases and their antimicrobial resistance pattern. This is a cross-sectional study of 1 year duration in which 121 pus and wound swabs were collected. Identification of isolates were done according to the standard methods. Antimicrobial susceptibility performed, extended spectrum beta-lactamase producers, ampicillin C beta-lactamase producer and metallo-beta-lactamase producers were identified as per standard guidelines. Coming to the results and discussion, out of 5,548 surgery done, SSI was reported in 121 cases. Thus, the SSI rate calculated was 2.18%, which is lower than the study conducted by Ravindra et al. It can be due to the inclusion of contaminated and dirty wounds in this study. So this is a bar diagram showing distribution of SSI according to the various age group. And we can see that in our study, majority of the SSI reported were among 31 to 40 years of age, which is comparable with the study conducted by Mehta et al. And on the right side, it is shown that superficial site was the most commonly reported, which was from which surgical site infection was the most commonly reported. And in second pie diagram, we can show the male preponderance was seen in our study, which is comparable with the study conducted by Budhani and Kalina et al. So total SSI positive cases were 121, out of which culture positive was 110, single isolates were 87, multiple isolates were 46, and total organism isolated were 133. So this is again the bar diagram which shows organism isolated from SSI cases, in which Klebsiella, which is 22.55%, was the most common isolate, followed by Escherichia coli and Pseudomonas aeruginosa. And this is similar to the study conducted by Anshula et al. And Kasugurti et al., which reported 19.8% and 29% Klebsiella pneumonia respectively. This is antimicrobial resistance of Staphylococcus species. Despite resistance to the many antimicrobials, it still remains sensitive to vancomycin and linezolid, which is similar to the study conducted by Nazin et al., who reported 100% sensitivity to vancomycin and linezolid. This is a table which shows out of 18 Staphylococcus aureus, 66.66 were inducible clindamycin resistance, and 6, which is 33.33, were methicillin resistance, which is comparable with the study conducted by Desi et al., who also reported 40%, and Negi et al. Reported 50.7% MRSA. This is the table showing antimicrobial resistance among Enterobacteriaceae. Here, minimum resistance was seen in Klebsiella for meropenem and imipenem, and among carbapenemes, maximum resistance was reported in for cefuroxime, followed by cefoxitin and cefotoxim. Same with Klebsiella pneumonia, and this is similar to the studies conducted by Negi et al., who reported maximum resistance to ceftazidime and gentamicin, and Budhani et al. Reported minimum resistance to imipenem. Out of 59 gram-negative isolates, ESBL producer was 28.81%, and MPC producers were 8.47%, which is similar. Study conducted by Mehta et al. Reported ESBL production in 50% of Klebsiella species, whereas Sanjay et al. Reported 23.14% of ESBL producers among gram-negative organism, with Klebsiella pneumonia being predominant. This is the bar diagram showing antimicrobial resistance of Pseudomonas aeruginosa and Acinetobacter baumannii, which shows maximum resistance to piperacillin, and same amount of percentage of resistance was seen for piperacillin, tazobactam, meropenem, and imipenem, which is similar, which is also showed by the Negi et al., who reported majority of the resistance to imipenem and piperacillin, tazobactam. And among 98 isolates, 21.42% was reported as MBL producers, which is similar to the study conducted by Sanjay et al. So coming to the conclusion, SSI rate in our study was 2.18%. Most common isolated organisms were Klebsiella pneumonia, followed by Escherichia coli and Pseudomonas aeruginosa. Among Enterobacteriaceae, for gram-negative, drug of choice would be carbapenems, and for gram-positive, drug of choice would be vancomycin and linezolid. Take-home message here is rise in prevalence of gram-negative organisms showing increase in antibiotic resistance is to be considered as a potential threat in upcoming years. There should be periodic surveillance of bacteria and antibiotic resistance, coupled with the implementation of strict protocols for antibiotic administration, and proper feedback of appropriate data to surgeons is highly recommended to reduce the SSI rate in developing countries. These are my references. Thank you.
Okay, nice presentation. So define SSI. Sorry? Define surgical site infection. Can you hear me? No?
Surgical site infections are defined as the infection which is caused after post-operative procedures within 30 days of the time limit, or for up to 90 days in case of implants and cardiac shunts.
In your presentation, you have mentioned about MC producers also. So how MC is detected in lab?
Ma'am, we detected it by putting the second generation cephalosporin with the third generation, and there is blunting of the zone in that. That is this antibody. Thank you, ma'am.
Thanks, Dr. Neha. Please collect your participation certificate from Dr. Archana. Now I call the next speaker, Dr. Smita Kulkarni from MGM Medical College, Aurangabad. Her topic for presentation is microbiological profile of infective keratitis in a tertiary care hospital.
Good evening, everyone. Today I will be presenting on the topic microbiological profile of infective keratitis in a tertiary care hospital. All we know that cornea is one of the most important and sensitive parts of the human eye, and it is vulnerable to a variety of infections because it is deprived of the usual defense mechanisms of the body. Infective keratitis is a major cause of mononuclear blindness in developing countries of Asia and Africa. Infective keratitis can be caused by different microbial agents like bacteria, fungi, viruses, and parasites. The epidemiological pattern of infective keratitis varies significantly from region to region. The successful treatment of corneal ulcer requires proper diagnosis and early initiation of appropriate antimicrobial therapy. The present study was conducted to help the ophthalmologist in effective management of keratitis and to know the profile of organisms leading to the infective keratitis in our area. The aim of the study to determine the microbiological profile of infectious keratitis at a tertiary care center in Maharashtra with the objectives to identify the bacterial and fungal etiology of the infective keratitis and to know the antibiotic susceptibility pattern of bacterial isolates. This was the cross-sectional observational study. It was conducted for the period of 2 years from January 2019 to December 2020 in the Department of Microbiology, MGM Medical College Hospital, Aurangabad. The patients with the clinical features of infective keratitis attending the ophthalmology outpatient department were included in this study, and the patients on prior treatment for infective keratitis were excluded from the study. Material and methods. The corneal scrapings were collected from each patient by an ophthalmologist with all aseptic precautions. Direct microscopy was performed by taking the scrapings on the 2 glass slides, one for the gram staining and other for the KH examination. Corneal scrapings were inoculated bedside on sheep blood agar and chocolate agar in multiple C-shaped streaks for the isolation of bacteria. The scrapings were also inoculated on 2 sabrodextrose agar slants for the isolation of fungi. The inoculated bacterial culture media were incubated at 37 degrees Celsius and examined after 24 hours for the growth. Bacterial isolates were identified by using the standard bacteriological techniques and Vitek-2 compact automated system. In vitro susceptibility testing of bacterial isolate was performed by Kirby-Beer disk diffusion method, and results were interpreted according to the CLSI guidelines. Inoculated SDS slants were incubated at 37 degrees Celsius and room temperature respectively. The slants were inspected every alternate day for up to the 3 weeks, and no growth thereafter was declared as the fungal culture negative. The SDS slants which showing a fungal growth were examined for the colony characteristics like texture and color of colony on the obverse side and pigment production on the reverse side. Lactophenol cotton tube preparation was done on mycelial growth for the microscopic examination. Coming to the results, a total 83 patients with the clinical features of infective keratitis were included in this study. Out of these 83 patients, 65% were males and 34.93% were female. The most common affected age group was the 5th decade of the life. It includes the 32 cases. All patients had unilateral involvement of cornea. Out of the 83 samples, 27 samples showed fungal elements on the KOH examination. By culture methods, microbial etiology, either fungal or bacterial, was established in 31 cases. The 5 samples showed mixed microbial growth, and remaining 47 samples had no growth. Among these culture positive 31 samples, fungal isolates were recovered in 21 and bacterial isolates in 10 samples. Fusarium species were the most frequently isolated fungus, followed by the Aspergillus fumigatus. Staphylococcus aureus was the predominant bacterial isolate, followed by the coagulase negative staphylococci. Pseudomonas aeruginosa was the only gram-negative bacteria isolated in this study. This table demonstrates the fungi which isolated from the culture-positive keratitis cases. Out of this, Fusarium species were the most predominant, accounting for the 29% cases. This table demonstrates the bacteria isolated from the culture-positive keratitis cases, with the Staphylococcus aureus being the most predominant bacterial isolate. It was isolated in the 12% of the samples. In antimicrobial susceptibility pattern of bacterial isolates, we use 6 different antibiotics against the bacterial isolates. Among the 6 antibiotics used, gentamicin, ofloxacin, and ceftazidime showed 100% susceptibility to all the isolated bacterial species. Coagulase negative staphylococci and streptococcal species were 100% sensitive to all the antibiotics used. This table demonstrates the antibacterial sensitivity pattern of the bacterial isolates. Regarding the discussion in this study, the culture positivity was seen in 37% of the cases. Similar findings were reported by Shoja et al. And Aminuska et al. They found 40% and 38% of culture positivity respectively. The fungal isolates accounted for 67% and bacterial isolates for 32% of the cases. This is accordance with the study conducted by Joshi et al. And Manikandan et al., who also reported that the 65% and 98% of the culture positivity. In this study, Fusarium species followed by the Aspergillus species were the most commonly isolated fungal pathogens. Srinivasan et al. Showed the similar findings, while the Basak et al. And Kumari et al. Have reported the Aspergillus species as the most common fungal pathogens in their studies. Staphylococcus aureus was the most predominant bacterial isolate in this study. Predominance of Staphylococcus aureus coincides with the study conducted by the Basak et al. However, in other studies conducted by Srinivasan et al. And Bharti et al., Streptococcus pneumoniae was the predominant pathogen. The most effective antibiotics in our study were gentamicin, ofloxacin, and ceftazidime, showing 100% susceptibility to all the isolates. Coming to the conclusion, infective keratitis is an ophthalmic condition requiring the prompt medical attention. Our study highlights that the fungal corneal infections are the more common than the bacterial infections in our study area. Successful treatment of corneal infections require proper diagnosis and early initiation of appropriate antimicrobial therapy. These are the references quoted in the study. Thank you.
Nice presentation.
Thank you, ma'am.
Did you try to find out why fungal causes were more common than the bacterial?
In our area, the vegetative trauma to the cornea is more common, And as the fusarium species, they are the common plant pathogen. We found that these fusarium species are isolated in more cases than the bacterial cases.
Okay, in case of fungal keratitis, other than fusarium and aspergillis, what other species are there which are responsible for fungal keratitis?
There are various dematicious fungi can isolated. In our study, we have isolated one species of Curvularia species.
Curvularia, okay. Any other from hyaline group of fungi?
Rhizopus and mucor species can also infect the cornea.
Okay, among fusarium, which species you got? You have done the speciation in case of
yes,
fusarium?
we have isolated the three species, Fusarium oxysporum, Fusarium solani, and Fusarium moniliforme.
Okay.
Thank you.
I request Dr. Jayashree to felicitate her with the participation certificate. Speaker Dr. Asmita. She's from Government Medical College, Akkola. Her topic is application of HUNET in antimicrobial resistance surveillance of isolates in tertiary care hospital.
Good evening all. Myself Dr. Asmita Karti from GMC Akkola. My topic is application of HUNET in the antimicrobial resistance surveillance of isolates in tertiary care hospital. So my presentation will cover introduction, methods, result, discussion, conclusion, and the references are attached. So now, why antimicrobial resistance? As it is a major public health problem. So the surveillance of etiology and the analysis of antimicrobial susceptibility test result is important for empirical therapy. For that, we have a software, that is WHO NET software, which is developed by WHO Collaborating Center for the surveillance and the antimicrobial resistance. So now why this study is carried out? As there is high prevalence of drug resistance, so this will cause the threat to the future treatment, so we carried out this study. Regarding the methodology, all the bacterial isolates from June 2021 to June 2022 were included. First, the isolation and identification of organism were done. Then later on, the AST was performed by Kirby-Ball disk diffusion method. And again, the data entry and the analysis were done by using WHO NET software. Regarding the result, one of the important data analysis option in the WHO NET software is isolate listing. So by using this, we can get the common isolates. So in my study, the 634 bacterial isolates were the total isolates. Enterobacteriaceae was common isolate. So by using this data analysis option, the most common species, I get Klebsiella pneumoniae having 25%. Later on, Escherichia coli is common, having 23%. Regarding the distribution of Klebsiella pneumoniae, as we can see, the corresponding month and the corresponding percentage of the isolates we can see. So the distribution of Klebsiella pneumoniae isolates, for example, in September 21, we can see that the isolates that is identified is 20. So in this way, we can find the distribution. So regarding the other analysis option, that is percentage resistance, percentage intermediate, and percentage susceptible option. So in that, we can find the percent of resistance isolate, percentage of the intermediate isolate, and percentage of the susceptible isolate. Here I am focusing the resistance isolate. That is, we can see the percent of resistance isolate to the each antimicrobial tested. For example, I am taking the common isolate that I found in my hospital, that is Klebsiella pneumoniae, and that Klebsiella pneumoniae is resistance to ceftazidime. As we can see, it is resistant to ceftazidime 70%. That is 70% of Klebsiella pneumoniae isolate is resistance to ceftazidime. We can see. Later on, The other drug is ceftriaxone, and the another one is cefotaxime. The least resistance is ciprofloxacin, that we can see the 10% of isolate of Klebsiella pneumoniae is resistance to ciprofloxacin, that is least resistance. So now, again, by using the same data analysis option, that is isolate listing and the percentage RIS analysis, the other common isolate I obtained is Staphylococcus aureus, that is 17%. And now I am focusing the percentage resistance, that result I obtained from percentage RIS analysis. So we can see the percentage of isolates resistance to each antimicrobial. For example, I am taking the Staphylococcus aureus, and the Staphylococcus aureus, that is 50% of Staphylococcus aureus is resistance to cefoxitin. Later on we can see the 40% of Staphylococcus aureus is resistance to gentamicin. Now, the least resistance is erythromycin, that is 10% of Staphylococcus aureus is resistance to erythromycin, that is least resistance. So now regarding the discussion, as we can see, the WHO NET software provides a uniform and a standardized platform, and in my study I got the common isolate as Klebsiella pneumoniae, which is resistance to ceftazidime. Then I compared my study to the two studies, that is by Vandana Agrawal et al. And A.N. Ghosh et al. In this, in Vandana Agrawal et al. Study, the common isolate was Escherichia coli, which is resistance to amoxicillin and clavulanic acid. And in another study, which is conducted by A.N. Ghosh et al., the Escherichia coli was the common isolate, which is resistance to ampicillin. To conclude with, we can see the WHO NET software helps in forming the hospital drug policy. It also helps in managing the resistance locally. Also, we can find the hospital outbreaks, and also through the exchange of data, we can collaborate with national and international networks. These are all my references. Thank you.
Okay, nice presentation.
Thank you, ma'am.
Do you faced any difficulties during using this WHONET?
Sorry, ma'am.
Do you faced any difficulties while using this WHONET software?
Yes, ma'am, some technical issues are there. Like in analysis parameters, we find some difficulty. We have the network, like we are under Mahasa network, so we approach towards the Aurangabad team to sort out that.
Okay, so you can recover that data which is lost during that problem, or you lost
it? Yes, sir. Yes, ma'am. We can recover it by using backlink software.
Okay.
What do you mean by cumulative antibiogram, and how it helps the clinicians?
Sorry, ma'am.
What is cumulative antibiogram, and how it helps the clinician?
Okay. It helps in forming the hospital drug policy. Okay. Antibiogram is the profile in which we can see the susceptible organisms to the antimicrobial tested, and that profile can be used for forming the hospital drug policy, ma'am. Thank you.
Thanks, Dr. Asmita. Please collect your participation certificate from Dr. Archana. With this, we conclude for the presentation. Now I thank all of you for patient hearing, and special thanks to our judges for their valuable time and input.
Thank you, everyone. Now I would like to request Meghna ma'am to kindly felicitate Dr. Jayshree Petkar ma'am. Thank you, Dr. Jayshree Petkar ma'am. Now I would like to request Dr. Archana ma'am to please come on the stage, please. Thank you, Dr. Archana ma'am, and thank you, Dr. Meghna ma'am.